The LD at School team is very pleased to welcome our guest speaker today, Dr. Marjorie Phillips, whose presentation is entitled Managing Anxiety in Students with Learning Disabilities. The Ministry of Education has provided funding for the production of this webinar. Please note that the views expressed in this webinar are the views of the presenter and do not necessarily reflect those of the Ministry of Education nor the Learning Disabilities Association of Ontario. We will also be tweeting throughout the webinar, so if you would like to participate, you can send us a tweet by using our handle @LDAtSchool or the hashtag LDWebinar. And that takes care of our housekeeping for this afternoon, so let's get started. It is now my pleasure to introduce our speaker, Dr. Marjorie Phillips. Dr. Phillips is the director of the Center for Mental Health Research at the University of Waterloo. From 2008 to 2017, Dr. Phillips was the clinical director for the Integra program with the Child Development Institute, the only accredited children's mental health agency in Canada to specialize in providing mental health services to children, youth, and families with learning disabilities. Dr. Phillips also worked as a clinical psychologist and the clinical director in a children's treatment rehabilitation center in Kingston for 12 years. Welcome, Dr. Phillips. The cyber floor is now yours.
Wonderful. Thanks to everyone, and I hope you can see my slides. I'd like to welcome everyone and thank you for attending this webinar on supporting students who have learning disabilities and anxiety. This is Mental Health Week, so this is a really fitting topic. And my hope today is to have more of an advanced topic on anxiety, exploring different types of anxiety disorders in order to help educators to understand the behaviors you may see in your students and to have ideas to know how to help. The 4 objectives. First is to understand the relationship. To understand the relationship between anxiety and learning disabilities. Second, to learn about common anxiety disorders in students. To understand what that means for the classroom and school environment. And lastly, to gain some practical strategies for how to help. And to understand anxiety, let's start by looking at what is fear and what is anxiety. Fear is defined as an emotional response to real or perceived imminent threat. If I'm alone in a house and a person crashes through my window into my living room, I experience fear. In contrast, anxiety is the anticipation of future threat. So after that incident of the crash, I may feel anxious every time I'm alone in my living room, worried that someone may intrude. And Barlow defines this anxiety as distress or uneasiness of mind, and it really reflects a fear of danger. And as I'll explain, anxiety is a basic human emotion that we all experience at some point, and it's part of typical development. Anxiety is a short-term stress reaction that's part of our human experience. If you were a hunter facing a saber-toothed tiger, your brain signals to you that you are in danger. Your sympathetic nervous system kicks in, and you may experience symptoms such as rapid breathing, sweaty palms, butterflies in your stomach, muscle tension. And our response to the perceived danger may be fight, flight, or freeze. When you encounter that tiger, you may fight the tiger, you may run away, or you may be frozen with fear. And the problem now is that the perceived danger may no longer be something like a tiger, but more like a math test, or having to read in front of the class, or having to navigate a school cafeteria. The brain perceives these situations as dangerous, just like a tiger, and reacts with an activation of the sympathetic nervous system. And we may respond with fight, flight, or freeze, yet this may not be adaptive for the situation. As I said, anxiety is a basic human emotion. It's hardwired and adaptive. Anxiety cues us to be alert. It is necessary and can even be helpful. For example, anxiety activates our adrenaline. It helps us to be energized, aroused, and that can be adaptive if you're running a race or giving a presentation or speech. Anxiety is also adaptive as an early warning signal for dangerous activities. You might get an adrenaline rush when you're skydiving, or if you're walking near the edge of a cliff or on a high ropes course, and that may help you to be just a little bit more vigilant and alert. But there are times when it's not so helpful to have an anxiety response. Sometimes the perceived threat may be something like a spelling test or talking to a group of students or even going to school. And the brain may respond as if we are in danger, activating all the nervous system arousal, but that really isn't helpful for the situation. So what do we know from the research about the relationship between learning disabilities and anxiety? We know that students with LDs have higher rates of anxiety. For example, in one study, 30% of children with diagnosed learning disabilities met criteria for an anxiety disorder. We'll talk about that in a minute. And it's common for students with LDs to have some level of anxiety. They may be feeling anxious at times or in response to specific situations, all the way up to meeting criteria for a disorder with more intense and impairing levels of anxiety. So if you work with students with LDs, the odds are that they may experience some level of anxiety at some point. It's pretty common for this population. These numbers are from one 2016 study of youth with learning disabilities who also met criteria for an anxiety disorder. And just of note, almost 30% of that sample met criteria for a generalized anxiety disorder. I'll talk about what that means in a minute. But it's also common to see students with LDs have social anxiety and specific phobias. There does not seem to be a gender difference. Both boys and girls with learning disabilities have anxiety at similar rates, although the presenting issues may look different, and I'll demonstrate that with case examples. One way to think about the relationship between anxiety and learning disabilities is to consider mental health on a continuum. And this slide is credit to Integra, a conceptualization that was developed at the Integra program at CDI, where, as Cindy said, it's a children's mental health agency that provides mental health services exclusively to children and youth with diagnosed LDs. So it's an opportunity to really learn a lot about these kids. In this continuum, many of us fall in the green zone, meaning that we generally feel pretty good. Doesn't mean that we're happy all the time, but we have social supports, we're engaged, we have sufficient personal resources to cope with everyday life things. Most of us occasionally experience periods where we move into the yellow zone of feeling stressed. Could be changes, a new job, a loss, a family member who's struggling, changing schools, stress at work. The demands exceed our resources. And we may feel a bit stretched, we may have difficulty sleeping, we may feel tense, we may feel overwhelmed. For many of us, the situation changes, or we develop new coping strategies, and we move back into the green zone. And sort of go back and forth sometimes. For some of us, the mental health issues are more serious and have a functional impairment. For example, we may have significant low mood and may have trouble getting out of bed in the morning, or may not get to school. That might be the red zone. So again, it's a continuum, and with intervention, supports, sometimes medication, we may move out of the red zone back into the yellow zone or the green zone. And I worked at Integra for over a decade, and there we saw a number of students with LDs mostly being in the yellow zone as their baseline, as sort of chronically stressed. School for kids with learning disabilities is often an ongoing stressor. By definition, it's hard to show what you know. School is a very social environment. We know that that's sometimes a challenge, and so forth. But for a portion of these students with LDs, so as high as 30% or possibly 40%, these students move into the red zone of more serious mental health issues, such as anxiety disorders. And at Integra, we called the subset of clients whose learning disabilities are complicated by mental health, learning disability mental health, or LDMH. So if you think about the students with learning disabilities in your school, I'd like you to take a minute to consider the types of everyday situations that might provoke anxiety or that fight, flight, or freeze response in your students. And just to reflect on what kinds of situations have you noticed that you can imagine would be anxiety provoking if you had an LD. So I'm guessing that many of you thought of things like these. There can be a lot of things in a school setting depending on the student and depending on the nature of their learning disability. So for some, it might be reading or writing in front of others. For others, navigating a social situation with peers, like having lunch or recess, unstructured time, or managing group work, figuring out how to hold conversations. For some, it's learning a new skill in gym and then having to go first without enough time to really see how it's done. So lots of things. I'm guessing that you, as you reflect, probably thought of other situations that you can think would be anxiety provoking. When we consider the interconnected relationship between anxiety and learning disabilities, it can be tricky to know when to be concerned. So that is, when is the anxiety a red zone problem or even a yellow zone problem that needs attention? One challenge in this is the overlap in symptoms between learning disabilities and anxiety disorders. For example, you might notice a student who has trouble concentrating, and that could be related to the student's particular learning disability with attention difficulties or a weak working memory, or they could be distracted by internal thoughts or worries. Similarly, you may have a student who doesn't follow instructions. Are they having trouble understanding or remembering the instruction? Do they need more time to process what you've said? Or did they miss the instruction altogether because they were worrying about something else? For some, rigid decision-making and difficulties shifting to a new point of view might reflect executive functioning problems. Or it could be because the student has OCD and has to complete a task 3 times before they can move on. And sorting out the relative contributions of social competence impairments related to the learning disability in comparison to social anxiety can be particularly tricky. So if anxiety is typical, and we all have it, and kids with learning disabilities are really likely to experience some extra level of distress in certain circumstances, how do you know when it is a problem, especially a problem for a student in your school, and a problem for which treatment will help? So the short answer is when it seriously interferes with the child's ability to do the tasks of everyday life. So it could restrict their ability to go to school or to hang out with friends at the mall, or it interferes with their concentration so much that they can't think about schoolwork or they can't sleep. When the anxiety is persistent, it's not just a period of time when a big change is happening. So for example, you may have a student who is not sleeping well and is really distracted in grade 8 because they're worrying about starting high school. But for it to be a disorder, it needs to be persistent and last at least 6 months. Also, when the intensity of the child's responses are outside of the norm, that becomes a key factor. So for me as a psychologist, when I'm doing an assessment and making a diagnosis, we try to get information about the child or adolescent from a variety of sources. The parents, the school, sometimes extended family. We watch the child in the assessment, and we find that often people will notice something that's just outside the norm with that child or outside the usual. Anxiety disorders are relatively common. The Canadian statistics for lifetime prevalence rates are here on this slide. And so all that means is that it's the percentage of the population who have an anxiety disorder at some point in their lifetime. And you'll see that the most common are social anxiety or social phobia and generalized anxiety disorder, with 8% and 5% respectively. But most anxiety disorders start in childhood. And one prevalent study from the States suggests that 12% of children meet criteria for an anxiety disorder. So again, it's fairly common among students in the school system. So who decides if an anxiety is a disorder, if the anxiety presentation is a disorder? Well, and what is the role of the educator with respect to identifying anxiety disorders? Educators are key because they may be the first people to raise concerns about a student, or they may validate how parents worry about their child. Educators have the opportunity to see a lot of children and adolescents of the same age, unlike parents who may not have a comparison group. But as I've tried to point out with the overlapping symptoms, diagnosis of an anxiety disorder is a tricky thing, especially for students with learning disabilities or ADHD, and it requires careful assessment, often the use of standardized tools and interviews and comprehensive knowledge. Diagnosis is a controlled act that can only be carried out by qualified professionals such as psychologists or physicians. So why does it matter whether a child is diagnosed with an anxiety disorder? Mostly because diagnosis can inform treatment. There are effective medications and evidence-based therapies, such as cognitive behavior therapy, that can be quite helpful. Okay, so let's turn over to the types of anxiety disorders. The Diagnostic and Statistical Manual, version number 5, DSM-5, is a system of classifying diagnoses, and it organizes anxiety disorders into 3 broad categories: anxiety disorders, obsessive compulsive disorders, and trauma and stressor-related disorders such as PTSD. For this webinar, we'll focus on just a few of these disorders, the ones I've bolded. So generalized anxiety disorder, selective mutism, social anxiety disorder, and obsessive compulsive disorder. Because these are the ones that I think you may see in the students you teach, and they're also the ones that are sort of tricky for the LDMH group, the students with anxiety and learning disabilities. So for this next section, I'll present one disorder at a time, identifying the key features, the consideration for the overlap between the particular anxiety disorder and the learning disability. I'll give you a case example, and then some specific strategies to consider. We'll start with the generalized anxiety disorder, or GAD. Students with GAD are the general worriers. They have excessive, unrealistic worries that persist, are distracting, and they interfere with everyday life. So these students, for example, might hear about what's happening in Syria, or on a bombing in a subway in London, or about the Zika virus, and are really worried about their safety here in Ontario. Or they may have fears about something bad happening to a family member. They may not be sleeping because of a worry that someone could break in or be kidnapped. Or they may have worries about their future, feeling like I'm going to fail this course, I'm going to drop out of school, I'm going to never get a job, the future is bleak. The nature of these worries varies across individuals, but the concept is that the worry is generalized, vague, and often hard to contain. I'll use this familiar metaphor of an iceberg, and the tip of the iceberg represents the behaviors you may see in school. For example, a student with both generalized anxiety disorder and learning disabilities, they may look inattentive and distracted. They may not follow instructions. They may be restless, Or you may never see them in your class because they miss class, they're sick, they don't have their work done. So those are pretty common kinds of symptoms that could be reflecting a lot of different things. And there are a number of possible contributing factors below the surface. So some of those or any of those behaviors could be reflect attention deficit hyperactivity disorder or difficulties processing language, tracking and remembering what you say, or it could be the student who's distracted by worries or have somatic symptoms or avoiding situations that make them feel bad or stupid. And often you have all of those or a combination of those. It's hard to know for sure what you're seeing, what the surface level behaviors really reflect. But an approach is to be curious and ask yourself what might be going on with the student. At the least, it gives you more options of things to try. So let's put a face on this kind of LD and GAD presentation. Trevor is in secondary school, grade 11. He seems very bright and articulate. He loves to argue his points in class. He often challenges his teachers on certain topics, and he points out situations he perceives to be unfair. He constantly asks questions in class around deadlines and upcoming schoolwork, as well as any changes in class schedule. Trevor seems easily distracted and inattentive. He frequently fidgets and seems uncomfortable in his skin. He often gets activated by his worries about schoolwork and change. Attendance is also an issue for Trevor, as he often cuts classes. And the tricky thing about GAD and many anxiety disorders is that they are internalizing disorders. You don't always see the inner dialogue. You may not see Trevor's worries about something bad happening to his family, or worrying about where he'll end up in life, or that he'll be mugged or attacked. What you might see, for example, with a student like Trevor, is that he appears oppositional and stubborn. He may sound like he's challenging authority. For example, when presented with a pop quiz, Trevor might go into fight mode and argue. You didn't tell us about this quiz. How am I supposed to know this? What you don't see, and what Trevor may not even be able to articulate, is in his internal worries. What if I fail this class? My parents and my teachers will be so disappointed in me. Everyone will think I'm stupid. I am stupid. And that's a core thought common to kids with learning disabilities that can really drive distressing feelings and can lead to avoidant behaviors. And these are just some of the behaviors you may see in a student with GAD. So school avoidance, illness, irritability, fatigue, inattention, perfectionism, not handing things in because it's just not good enough. But again, every student is different. What can you do to support a student like Trevor with generalized anxiety disorder and learning disabilities at school? We'll talk a lot at the end about some general strategies that are helpful for all types of anxiety. But related to GAD in particular, we know that structure and predictability is often helpful, as well as being empathic and patient, recognizing that the questions are coming from a place of anxiety and not belligerence. Understanding that advanced notice might help, sort of figuring out what are the triggers that might really get this kid's anxiety flaring, and is there anything you can do to mitigate that? So for generalized anxiety disorder, the universal practices for stress management, such as mindfulness and breathing, that can be helpful for everyone, but especially for the student with GAD and LDs. Okay, so we'll talk next about social anxiety disorder, or it's also called social phobia. You see the words used interchangeably. Social anxiety is a common and complicated problem for students with learning disabilities. According to the DSM-5, this reflects a marked, intense fear of social situations. And for children and teens, the social anxiety has to pertain to peers. It can't just be a fear of strange adults. So it could be meeting new people or having a conversation. eating in a public place like a cafeteria, and performing before others. So it could be in a presentation, like giving a speech, or in a musical event, a choir or a band, or a sports team, like an athlete. And typically, the key thing is that the student may have significant worries about what others will think, or they worry that they will feel humiliated or rejected. The other criteria for social anxiety disorder is that the person either avoids social situations or they endure them, but they experience significant anxiety that is out of proportion to the situation. And these symptoms have to have lasted for at least 6 months and cause significant impairment. And it's not always obvious. I've worked with a teenager who had significant social anxiety disorder, and he was a star athlete who had anxiety about his performance that got worse as his athletic skills improved, and he rose up the ranks to becoming quite a high-level performer, where the anxiety got really debilitating, but the coaches just didn't see it initially. So, individuals with social anxiety disorder usually engage in what are called safety behaviors. And safety behaviors are defined as cognitive and behavioral strategies used by socially anxious individuals to reduce the risk of negative evaluation by others, by Clark and McManus. And we know from the research that highly socially anxious children use safety behaviors more frequently than non-socially anxious people. The tricky part is safety behaviors look like a lot of other behaviors. So you might see them in your classroom. They're common and can mean a lot of things. For example, students who don't make eye contact, or who wear hoodies or have long bangs that hide their eyes, or they may be the students who are really trying to avoid calling attention to themselves by how they sit, how they look, what they wear. They may be the students who offer to help out at a function by taking tickets at the door because they don't really want to be involved in the performance. Or they may be the types that are sort of daydreaming or look like they're zoning out. The overlap between learning disabilities and social anxiety is particularly tricky. 75% of students with learning disabilities have difficulty in social situations, but often that reflects the impairment in social competence. It could be misperceiving social cues or misunderstanding intentions related to their LD. And then the outcomes with the student with LD is that social interactions don't always go well. So as a result, students may begin to feel anxious. They may feel that they're not very popular, or they're seen as an outsider, or that nobody wants to be in a group with them. And that all may be related to the learning disability. And still valid and important to support, but different. So it can be tricky to figure out if there's an additional social anxiety disorder on top of the LD anxiety. And important to do so because in order to treat the disorder, we want to take into account both social competence and anxiety together in the intervention. A social skills group that doesn't attend to the social anxiety may not be so successful. And conversely, a social anxiety group may really not give the kid enough skills and practical cueing for navigating a social relationship. So let's consider Jenny. Jenny is a 12-year-old student in grade 7 who has both LDs and social anxiety disorder. She's always had trouble making and keeping friends, and she finds it hard to follow a group conversation. Jenny perceives that other students don't like her and are mad at her. She experiences tremendous anxiety even thinking about going to school every morning. She makes little eye contact, doesn't contribute to group work, avoids the cafeteria, and stays away from school on days when there are assemblies. She feels lonely and like an outsider, but doesn't know how to change things. So what might you do as an educator to help someone like Jenny? Besides accommodating for the learning disability and referring her to your student support team or mental health professionals, that's sort of a given, You can be thoughtful when you're implementing group work. So instead of allowing students to pick their own partners, assign carefully and pair Jenny perhaps with a kind, socially skilled student who will be patient. You could talk to a student like Jenny about a plan for crowded events, such as assemblies. And if possible, helping a student like Jenny to find a role and structure for unstructured time, such as recess. For example, there may be an opportunity for the student with social anxiety to help with the kindergarten class, but pairing them with another student from her grade, for example, so that it's not it's destigmatizing, it's sort of a normative thing. It gives her a chance to have small group interaction. That would be an example. Okay, let's switch to selective mutism. Selective mutism is a relatively rare disorder occurring in less than 1% of children, and it is more commonly seen in young children in comparison to adolescents. Usually starts before the age of 5 years, but often the behaviors become a significant impairment when they start school, such as in kindergarten. Students with selective mutism can speak. However, they're usually silent in situations when speech is called for, such as in a classroom. And for diagnosis, the behaviors have to have persisted for at least a month to meet diagnostic criteria, and they have to be impairing. So typically, a vicious cycle occurs in which the child is asked a question or encouraged to verbally participate. The child with selective mutism will respond with anxiety, and they often freeze and say nothing, perhaps may gesture or shrug. And the caring adult sees the child in distress and comes to their aid and answers for them. And often, especially with young kids, other children in the class will do this too and sort of say, oh, Johnny doesn't talk, and so they'll talk for them. And that works in the short term. The anxiety levels decrease for the child with selective mutism. All the adults and caring people around feel like they're helping, and yet the child with selective mutism doesn't really get to override that danger signal to learn that it is safe to speak. And thus they negatively reinforce the safety behavior of silence. So much like social anxiety, there's a lot of overlap with students with LDs and selective mutism, although it's a little less common because often kids may not be identified with an LD until they're a little older. But it's the same kind of social piece, not initiating interactions, being withdrawn or quiet, and figuring out what's a language impairment, what's a lagging social competence, what's anxiety. It's important. Consider Naomi. Naomi is a shy and quiet grade 1 student. Her classroom teacher has never heard her regular speaking voice. It has taken until Christmas for Naomi to whisper to her teacher. The other children in the class assume that Naomi doesn't speak, and they'll answer for her. Naomi often looks out the window and appears distracted. Her parents are frustrated because at home with her 4-year-old sister and her parents, Naomi is a chatterbox. So as with the other anxiety disorders, it's really important to flag concerns and to ask about a referral if you think your student may have this problem. But, once that's been sorted out, what can you do in the classroom? You can create a safe environment and gradually support the student to voice his or her ideas to you and then eventually to the class. So initially, for example, it can be helpful to express ideas and observations to the student so they feel part of the class without the pressure to respond. You might start with questions where the student can nod yes or no. Like if you're working with a grade 1 kid, do you think the girl will find her necklace in this story? So that the student's still part of the class. And then over time, asking questions that require a verbal response. Would you like this or that? And if you have a student who whispers, then simply repeating what the student said to the class. And as always, pairing thoughtfully for any group work can be helpful. The last disorder that we'll talk about is obsessive compulsive disorder, or OCD. And OCD is commonly not diagnosed until late adolescence or early adulthood. However, 25% of adult males with OCD report their first symptoms started by the age of 10 years. The disorder is characterized by obsessions, or recurrent and persistent intrusive unwanted thoughts, images, or urges. The key feature here is unwanted thoughts. Often youth with OCD are aware that their worries are irrational. They may feel a sense of shame and want to hide what's happening. Compulsions are behaviors that are aimed at reducing the anxiety associated with the unwanted thoughts. They're often excessive, such as hand washing frequently, showering for hours, or counting items repeatedly. Of note, children or students may not be able to explain why they do the behaviors. They know the behaviors don't make sense, but they feel compelled to do them to feel safe. Common examples are worries about being contaminated by germs or disease, and then developing cleaning and avoidance behaviors to feel safe. Similarly, students may have worries about safety or harm and may engage in what seems like superstitious behaviors, counting or repeating something 3 times, or checking and rechecking locks, for example. Students who have LDs and OCD can be challenging, particularly if they're also on the autism spectrum. So, for example, rigidity and repetitive behaviors may be part of ASD, autism spectrum disorder. They may be part of OCD. They may be rigid coping and executive functioning related to LDs, or all 3. And sometimes it's tricky to know what to make of it. Sometimes it can be helpful to know whether the behaviors are welcome for the child or not. So are they ego-syntonic or ego-dystonic? For example, if the student is aware that this way of thinking isn't logical, if they feel embarrassed or shamed by needing to complete rituals, it may be more anxiety and OCD, but the professional assessment and intervention is really important. So consider James. James is a 15-year-old student in grade 10. Academically, James has always found school difficult, particularly reading and writing. He's really good with mechanical things and with his hands, but this year he seems preoccupied and disengaged. He liked gym in grade 9 and was a good athlete, but this year he started to avoid touching sports equipment like soccer balls and basketballs. Things became awkward during a class presentation when another student handed him a dry erase marker to write on a whiteboard, and James left the classroom. And as his teacher, you've noticed that James won't touch something after someone else has touched it. But he doesn't say anything. So the recurrent theme for all these anxiety disorders is consult with the family and professionals who are treating the student to know what to do for that particular child or youth. For OCD, we know that the treatment of choice is cognitive behavior therapy that includes exposure and response prevention, or ERP. But I think from an educator's perspective, creating a safe environment and avoiding publicly embarrassing or shaming the student, just really knowing that this is the student's not doing this to get attention. They're often embarrassed. And if you know the nature of the compulsions, there may be a way to support the student working with their treatment team, like giving them a computer instead of writing, or giving more time, because you might have a kid who has compulsions around tapping at the end of each math problem set and needs more time on a test, for example. Okay, so we've talked about some strategies that might be helpful for the particular anxiety disorders. And in the last segment of the webinar, we'll just review some general strategies that are helpful for students with learning disabilities and anxiety who are in either the yellow or red zone. And there's resources at the end, including the Supporting Minds reference and a handbook on learning disabilities mental health by Integra that's helpful. So as I've said, the first step is to recognize and identify signs of potential mental health problems. If you're concerned, then it's important to share your observations with others who can help develop a plan to support the student. And often mental health issues are complex and require a careful assessment. So talking just to see where that might happen or if anybody else has concerns is a good first step. A team approach with caregivers, school staff, other professionals is really important for mental health challenges. It can be hard to communicate with each other. It can also be hard to access resources. And I know that often there are not enough mental health resources in the community for these. But at least pulling together with the resources you've got to have a team is an important start. And each school board will have its own procedures, but all boards usually have a process that educators can use to raise concerns about students that are experiencing mental health challenges. So these are strategies that are really good for supporting mental well-being, good for everyone kind of in any zone. One is to get to know your student and know their strengths and weaknesses, knowing what situations they can handle and how to respond when they can't cope to the extent that you can. Where it's appropriate, normalizing or educating your students on anxiety and helping them to understand what's by role modeling or highlighting fictional characters, just how it's fairly typical to have anxiety. Changes of any sort may be very stressful for students with learning disabilities. So predictable schedules and routines, warnings when transitioning, as well as clear expectations can help students predict how the day will go. And that may help to decrease opportunities for emotions to build up, and also give the student time to process information and ask questions if they need to. Having a quiet and safe place where your student can go for a few minutes to calm down, like a resource room or a library that you work out with the student ahead of time, can be helpful. And also knowing the individual student, you might seat the child in the classroom deliberately near the front where it's quiet and less distracting, or you may choose by the door so that the student can feel they can escape and leave when they need to. If you have a student who's overwhelmed by sudden changes or large crowds, as I suggested before, planning in advance for assemblies or large group activities might mean sitting on the end of a row or arriving early or late. It all depends on what makes sense for the student and what makes the student most comfortable. And again, group work is really important instead of letting students pick their own groups, because students tend to gravitate towards the peers they know and who are familiar with, and they often leave out students who may not have a close relationship with their peers. And if you're the student with anxiety, picking your own group can be really anxiety-provoking, especially if you have few friends. And lastly, if you have a student who's spending unreasonable amounts of time on homework, or they're simply worrying about completing an assignment properly, then again, working with your team, adjusting or reducing the amount of work, focusing on effort, not outcome, may help. Children and youth often learn self-regulation skills by observing others. So modeling optimism, positive behavior, understanding, accepting feelings, emotion regulation, positive self-talk, all of those things can be helpful. And creating a learning environment where mistakes are viewed as a natural process, part of the learning process. So providing students with reassurance after a mistake is made. Everyone makes mistakes, or no one's perfect, or it's how we come back from the mistakes that matter. More and more, we're learning about the benefits of mindfulness. And so teaching mindfulness to the class as again, good for all sort of strategy, or practicing relaxation skills throughout the day, taking breathing, having mini breaks. We know that that's really good for good mental wellness. And praise is important, but for students with learning disabilities, they're often really aware of their academic or social difficulties. So ensuring that your praise is genuine and meaningful, and praise reinforce efforts, not just results, is important. And for the student with anxiety, empathy is often the best place to start. It may start with noticing a student who's struggling, and in a tactful manner, finding an opportunity to pull the student aside and listen to their concerns, or just check in. You might help to reflect and label the feeling. So for example, saying to a student, I noticed you're asking a lot of questions about the upcoming field trip. Are you a little worried about how it'll go? you can also validate their feeling by understanding and not judging why a student might feel that way. So you might say, for example, lots of people feel sort of nervous when they have pop quizzes. And then lastly, supporting the student's strengths. So again, not giving false reassurance, but really a genuine acknowledgement of effort, saying to the student, you've worked hard, you've put a lot of effort in, you're ready. But you don't say you're going to ace the test, especially with kids with LDs, because you just don't know that. And as an educator and adults, caring adults, we need to stay calm ourselves when a student's anxious and develop some strategies. It might be a cool down pass or a signal when they need a break. There are some visual aids for elementary school kids that can be helpful, that you can post in your classroom with those cool down strategies. And lastly, just reminding us all that it's less effective to have a teachable moment when a student is fully dysregulated, or if they're really anxious, their brain is offline, they are not able to concentrate and really process what you're saying when that sympathetic nervous system is fully aroused. So finding a time to debrief or problem solve when the student is calm, when you're calm, is really important. And I'll leave you with the tip that I think is the hardest, is to avoid or resist asking too many why questions. Especially for students with anxiety, they may not know why, or they may not be able to articulate why they feel overwhelmed and anxious, especially in the moment. What's really helpful is just validating and helping them to regulate and find their way back to calm. So as you'll see in the slides that will be sent out to you, there are good resources. I'm now at the University of Waterloo, but I want to put a plug in for my colleague, Haley Stinson, who is a social worker with the Community Education and Engagement Program at Integra at Child Development Institute. And Haley is, and the Integra folks can come out to your school, to places to give workshops to staff, to students, to parents on a variety of topics related to LDMH. Or there are some workshops in Toronto that you can look at. And then we also have good information on the website that may be of use to you. So as you'll see in these resources, Supporting Minds is a fantastic document from the Ministry. School Mental Health Assist, you're probably aware of. Children's Mental Health Ontario has lists of agencies, children's mental health agencies that are in your region. And Integra has information, and then again, lots of great resources that you'll see for educators. And I will leave it there and pass it back to Cindy. Thank you.
Thank you very much, Dr. Phillips. That was a fabulous presentation. We're so appreciative that you've taken the time today to share your knowledge and your expertise, and for providing our webinar participants with incredibly in-depth practical suggestions and strategies to manage anxiety in students with LDs. Okay, so let's move on now to the Q&A part of today's webinar. If anyone has questions, please type your question into the chat box on your GoToWebinar dashboard, and I will read your question to Dr. Phillips. First question, and this is actually a two-part question. Part one, is it common for students with learning disabilities to experience multiple mental health concerns?
Can I answer the parts one at a time?
Yes.
Yes. So yes, comorbidity is really common with LDs. I think we're just learning really about these, we call them LDMH folks, but a common thread seems to be emotion regulation challenges and executive functioning difficulties. But it's quite common that you'll see anxiety plus depression plus ADHD plus LDs plus sometimes ASD comorbidity is really quite common.
Okay, thank you. Part two of this question. How then can teachers support students with learning disabilities who have complex mental health needs?
Well, I think I feel first for educators because I think all of us are trying, these students need all of us to work together, but we're really set up in different, you know, our services are not always accessible easily. So I think the biggest thing that educators can do is to really help to say, you know, I'm worried about this student, and just to pull in at your school board level to flag it, to say, I'm worried. I think you know, this student is acting really defiant, or he's not, or I never see him. I don't even know what he looks like. He never comes to class. And just to pull the alarm bells off. There are wait lists everywhere, but more and more in Ontario, we have drop-in clinics, we have services, and then I think the school mental health and other leads are really trying to beef up resources. So for the educators, it's not feeling like it's your job to do the intervention. It's you have a fantastic job to flag concerns and raise alarms. And then support in these kind of generic universal strategy kind of ways.
Thank you. Next question. Can a student display signs of obsessive thinking without manifesting compulsive-like behaviors?
Yes, absolutely. Yeah, OCD isn't only defined if you don't have to have compulsions, you know, necessarily. It's just fairly common. One of the tricky parts in diagnosis of obsessional thoughts is just how much is it really obsessive compulsive disorder and how much is it generalized anxiety disorder. So you can have students where they have worries and they're vague and they're intrusive and they just can't let them go. But they're not obsessions. And it's you know, a nuanced point. In some ways it doesn't matter so much, because either way, if the thoughts are intrusive and they're concerning to the student, then working with someone to help them, you know, figure out what those thoughts are and how to change their thinking is important. And the last comment I'll make about that is that sometimes the compulsions might be not noticeable. You might, you know, that there may be a compulsive piece that you don't see because it's the students counting in their head. You know, it's not hand washing. So sometimes there are compulsions that are part of it that are invisible.
Great, thank you. Next question. How would you handle the situation where a student has a diagnosis of ADHD, experiences significant anxiety, and the learning gap is increasing, but parents are not in favor of medication to help manage ADHD?
Right. Yeah, I think that's such a big piece. It can be, you know, with or without the anxiety. That's a big piece. I think my experience from working with families a long time is it helps to give the family some time and having a relationship with someone to really understand what their concerns are about medication. So it's tough again, I feel for educators because, you know, you get to see a whole classroom and you can see, my gosh, if that kid had something to take, you know, to help bring their focus up or bring the anxiety down, they could really attend better, or it would be so much better. But, you know, it's respecting the family values. It's helping the family to start to see somebody where they can really talk over their worries with more time and get to know what the concerns are. It's often not just as simple, you should just do it. You know, you have to understand. So in the meantime, I think for educators, it's managing what you can do with the student you've got and doing environmental changes to the extent that you can, like seating and cueing, that sort of thing.
Mm-hmm, mm-hmm. The next question is cognitive behavior therapy, CBT, possible with a youth who has had a diagnosis of selective mutism for 5 years and is completely nonverbal outside the home? This particular youth is now 18 and became nonverbal at age 13.
Oh, wow. So I don't know enough about the specifics, but I would be really curious about, that's not a common trajectory for selective mutism. It may reflect some complexity related to a trauma or something having changed for that individual. So that's, yeah, so I'm guessing often for complex pictures that are outside the typical presentation, like having selective mutism at 18 with an onset at 13, and the typical treatment as usual often is less effective, and it may take a combination of a lot of things, including really like medication and careful therapy. It depends on the student's willingness to engage. There may be other factors. I would certainly want to be sure that there was a really good assessment being done to make sure there isn't something like a brewing schizophrenia or autism or something that could also account for a change in that kind of reduction in talking or with loss of function in that way. That's just atypical.
Okay. We have so many questions here. I know we're not going to get to all of them in the time that we have, but I will. I'll read a couple more and give people a heads up when we're at the last question. Elopement, leaving school and running home. Are there specific strategies that we can use?
Yeah, wow, that's such a tough one. It often depends on the age of the child. So, safety is paramount. If you have elopement in a 6-year-old, that's different than elopement in a 15-year-old, which probably wouldn't even call it elopement. So I think so again, pulling together the team, trying to understand what are the situations that, if you think back to that very basic fight, flight, or freeze, that's a classic flight, literally flight. The child is running away from school to get to the safety of home. So what is it about that school environment that's really flaring up that anxiety? Is there a way to work with the student and the staff and the family to change the contingencies? Maybe it's a particular teaching style, or maybe it's a class, or maybe it's a time of day, or maybe it's just that it's just too much. They can get to school, but they just can't, they worry all day, and by the time they hit 11 o'clock, they're done. And so changing their length of day till you work back up, it sometimes can be things like this child can be attention seeking, but often there's some kind of a distress that starts it off, and understanding. But in terms of strategies, it also depends on the specific school location, and whether or not you need to, because you're worried about the child running into traffic, and have an adult outside. Or it's all quite specific that way.
Yes, I know there are a lot of variables that have to be factored into any sort of an intervention plan that is put into place. What happens when anxiety and learning disabilities are diagnosed later rather than earlier, and oppositional behaviors seem to be out of control?
Well, I think again, sometimes a good diagnosis of some of these things can be tricky. So it can be the case that the student had learning disabilities all along, but they kind of grew into their areas of impairment and they become more evident. It may be that you can develop anxiety disorders can emerge. They don't all start at a young age, so those can emerge. And oppositional behavior, I think, is often one way to look at when a student is just refusing to do what they need to do. And so that diagnosis can be helpful, but oftentimes it's just more of a description of sort of what's going on. Why is the student digging in their heels? Is it anxiety based? Is it competency based? Because they need more supports. And unfortunately, the later the diagnosis, especially for something like LDs, then you can get pretty entrenched behaviors in the student. They can feel like giving up, or that what's the point? Every time I do something, it just is the outcome's it's not worth the effort I put in, so why bother? And so then that it just gets harder to manage as you get older. But again, the principles would be a good diagnosis and pulling your team together and looking at what are the situations where a student can experience success and trying to build on the successes bit by bit.
Our next question here, and I think we will have time for about another 3, just so you're aware as well, Dr. Phillips.
Okay.
What
I lost
you. Students with learning disabilities and mental health?
Sorry, Cindy, I only heard the learning disabilities and mental health. You cut out at the beginning.
Okay. Not a problem. So I'll repeat the question. Okay. What are your thoughts around evidence-based social skills training for students with LD and MH?
Right. Well, I'm a biased. I'll state my bias right at the top. At Integra, we developed a social competence intervention that we're evaluating that's really promising. It's not an evidence-based intervention as yet. But having read a lot in the field, I think the interventions need to be multifaceted, and that's if people are interested afterward, they can contact me. I have some good resources and articles and so forth. But the key thing is that to consider social skills and self-regulation and social awareness as all different components of social competence, and that students with LDs, we need to take their learning into account when understanding that, and then adding in anxiety if that fits. So we know from the research that social skills alone don't always generalize, but if kids learn by doing, they learn from each other, and if we can provide in the moment coaching and we match kids so that they're learning from the right other kids, they learn from each other, and we've set the contingencies effectively, and we're targeting the skills that they need to learn, like conversation or turn taking or awareness, that those skills seem to be generalizing much better.
Okay, thank you. Second last question now. Is there any research showing a connection between the non-treatment / diagnosis of learning disabilities and anxiety disorders?
Sorry, so research showing the non-treatment diagnosis? Is that what you said?
That's the question here. So I'm wondering if research has a control group so that there might be students who don't receive specific interventions or support to address LDs and anxiety.
Right. Oh, meaning like a control group. I'm guessing maybe that's the question is, have there been controlled studies of intervention in anxiety?
That's how I would interpret this.
Yes. Okay. So the literature in this field is really sparse. I think there's one of the challenges is just even internationally is our definitions of learning disabilities and how that's defined in different studies. And so, but in terms of controlled studies, what hasn't been there is people really tailoring interventions in a controlled way to look at, what difference, how the tailoring works, or whether students with LDs have been compared to non-LDs for intervention. But certainly for diagnosis and prevalence, we know that that's compared to control samples. If you have students with, how many students with anxiety versus how many students with LDs and anxiety is there. But I think more controlled studies are needed. And there's, even at Integra, I think that's been our aim when I was there, was trying to conduct controlled studies and compare, but we were comparing students with LDs who weren't in treatment to students with LDs who were in treatment. That was the control group.
Okay, yeah, and I think that that answers the intent of the question. And this is our final question then for the afternoon. My goodness, there are so many great ones here. Actually, the question that I'm going to pose to you has come up a couple of times in what our webinar participants have submitted. If anyone participating today has a student-specific question for you, would they be able to contact you directly?
Oh, that's a good question. So, because I'm in my old role, yes, absolutely. In my new role, yes. I'll answer. I'd be happy to. I'm now at the University of Waterloo in a different kind of position, but this still is a passion area. I also think the Integra Community Engagement and Community Education and Engagement Program is really the aim of that program. That's our old program, is to facilitate knowledge transfer and support. So yes to both. My contact information is there. I'd be happy to chat.
All right, wonderful. Thank you very much. So that's all the time we have for today, and we're going to end our question and answer session at this time. Should you have any further questions, please either email us at info@ld@school.ca or use our hashtag on Twitter, LD Webinar, and we will ensure your questions get answered. Please mark your calendar and save the date to join us at LD at School's 5th Annual Educators Institute, which will be held on August 21st and 22nd in Mississauga. Public registration opens on May 14th. Please check the LD at School website for information on the program, registration, and hotel accommodation. And on behalf of the LD at School team, I would once again like to thank Dr. Phillips for her presentation, and thank you to all of our participants for joining us. Please remember that we will be sending out presentation slides and a short survey following today's webinar. The feedback we receive through this survey provides us with important information for producing future webinars. And as a final reminder, we will be sending out a link to this recorded webinar in approximately 3 weeks. Thank you again for participating, and enjoy the rest of your day.